Hello, everyone. Thank you for joining us today. My name is Frida Pineda Sandoval, and I will be helping moderate today. I am the Training and Technical Assistance Manager here at NCHPH. Today, we will be hosting a webinar on the challenges in the development of diabetes prevention in public housing settings, brought to you by NCHPH. So before we get started, we're going to go over a few housekeeping items. Just a reminder that all participants are muted upon entry. Please make sure that you engage in the chat if you have any questions or any comments or any promising practices that you would like to share with us about today's topic. Please make sure that you also raise your hand if you would like to unmute. This meeting is being recorded, and the slides and the recording link will be sent via email to all participants after today's webinar. So about the National Center for Health in Public Housing, NCHPH, the mission is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees that by providing training and a range of technical assistance. NCHPH is supported by the Health Resources and Services Administration and is also a national training and technical assistance partner funded 100%, financed 100% by this grant. The information that will be shared today are those of the author and does not represent the position of HRSA, HHS, or the US government. So this is just some background information about health centers that are close to public housing. As of 2021 UDS Health Center data, there were 1,373 FQHCs that served to 30 million patients, 458 FQHCs that are in or immediately accessible to public housing that serve to 5.7 million patients. And of those 458, there were 108 PHPCs that served to over 900,000 patients. In terms of public housing demographics, this is just a brief overview about the characteristics of public housing residents. So as of 2022 HUD resident characteristics data, there were 1.5 million residents with 2 persons per household. There were also 91% that were low income, 32% were female-headed households with children, and then more specifically, 52% were white, 43% were of African-American descent, 26% were Latinx, 19% were elderly, and 36% were children. So today we have the honor to hear from Dr. Jose Leon, who is a clinical quality manager at NCHPH, and from Francis Ephraim Jennings, who is the Chief Executive Officer at Camillus Health Concern. Dr. Jose Leon is the Clinical Quality Manager at NCHPH, and in his role, Dr. Leon provides training and technical assistance to community health centers, serving public housing residents on emerging clinical topics and quality improvement, quality assurance systematic actions that lead to measurable improvement in healthcare services and the health status of underserved and vulnerable populations. Dr. Leon also heads clinical quality and emergency preparedness working groups that provide assistance training to community health centers across the nation. Francis Ephraim Jennings is a senior healthcare executive with 2 decades of substantial industry experience. Ephraim Jennings' passion for overseeing large institutions with a personal touch is contagious and has strengthened and motivated the staff, patients, and community wherever he has been. Ephraim Jennings' work has transformed multiple organizations, raising their profiles through streamlining operations and bringing in additional resources to exponentially expand their footprint. As a Chief Executive Officer of Camillus Health Concern, Inc. in Miami, Florida, for nearly 5 years, he sought and received nearly $10 million in government and philanthropic support for vital services and expansion. So for today's learning objectives, we will discuss the prevalence of prediabetes in public housing. We will be summarizing the challenges for diabetes prevention and interventions, and we will also identify interventions that address prediabetes in public housing. So without further ado, I'm going to pass it on to Dr. Jose Leon.
Thank you, Fide. Good afternoon or good morning to you, depending on where you are in the country. It's such a great pleasure again to be part of this webinar, diabetes webinar series that we have been hosting for the last 3, 4, or 5 years since HRSA made diabetes a priority. It's been a long journey, and we've been working on different aspects, prevention and management, looking at challenges, providing recommendations, promising practices. So today, as Fide mentioned, we are going to discuss some of the challenges in public housing to offer diabetes prevention and to prevent diabetes in this particular population. I am very pleased and very honored to co-present with Francis, who's been involved in public housing for many, many, many years, not only now in South Florida, but in Cleveland, Ohio. And so he is the right person and who knows not only the public housing population, but the homeless, the homeless population in both states. So thank you so much, Francis. It's just as a reminder, we've been working with HUD for many, many years and the Centers for Disease Control and Prevention, trying to obtain the data on the health characteristics of those living in public housing. And it's very important to mention that overweight and diabetes are two conditions that are prevalent in public housing and are one of the most important conditions affecting those living not only in public housing developments, but those receiving assistance from HUD. As you can see, the percentage of those with diabetes in public housing is almost 18%, and 71%, which means 7 out of 10 of those living in public housing are either overweight or obese. We can see some other conditions that are going to worsen diabetes and that are very prevalent in public housing. We have the COPD, asthma, and we have around 33%, almost 34% of those living in public housing who are current smokers. And as you know, that is going to increase the risk of developing diabetes, cardiovascular diseases, and other chronic medical conditions affecting public housing residents. Next slide, please. Prediabetes is a huge issue in the United States and everywhere. It's a public health emergency. WHO has a recent publication just informing and warning governments about the increase of diabetes and prediabetes in everywhere. So we know that in the United States, 33% of those living in the United States have diabetes. But what is important is that 80% of those with prediabetes don't know that they have prediabetes. So this is alarming because sometimes people have no symptoms, have no signs, and yet they are at risk of developing diabetes in future years. Next slide, please. As we know, obesity, overweight and obesity are two risk factors that can lead to diabetes. And just a quick reminder about the BMI and what it means when you go to a clinic or if you are a provider and you are measuring BMI in your patients, and you see that if it is under the 8.5%, the patient is underweight. If it is between 18.5 and less than 25 is the healthy weight range. over 25 and less than 30 is the overweight range, and 30% or higher, this falls within the obesity range. Next slide, please. Healthy People 2030 has good indicators and some alarming indicators about the prevalence of prediabetes in the United States. These numbers were taken from NHANES, the CDC's survey, the National Health and Nutrition survey, and the results indicated that 38% of people have undiagnosed prediabetes. And the target for the next few years is to try to reduce the percentage to 33.2%. So this is just a quick reminder that not only our health centers and state health departments, but federal organizations are working on addressing prediabetes, so fewer people are experiencing diabetes in the near future. Next slide. In regards to obesity, that as we mentioned, this is one of the risk factors. The target that Healthy People 2030 is looking is at 36%. However, according to NHANES, the results from 2013 to 2016 was 38.6% of the population were either obese, overweight or obese. And for the 2017 and 2020 data, instead of going down, and despite of all the prevention services and everything that we're doing, the number is going up. So 41.8% of the population is either overweight or obese. Again, our target for the next few years is to try to reduce this number to 36%. Next slide, please. The other issue is by state. I mean, when we see data by a state, we see that the numbers have been increasing, and the number of those who are over 35%, if you see the red part of the bar, are the numbers are also increasing. So in 2021, 41%. You know, I mean, in 19 states in the United States, referred to have obese people over 35%. So again, this is something that we need to take into consideration, making sure that we address it and make the changes or provide the resources or find the resources to help our populations to find the right ways or the right interventions, to find the right ways to try to decrease these numbers. Next slide, please. HRSA, and this is UDS data in regards to BMI. The percentage of those patients who are measured and the BMI is measured and then they have follow-up plans is 61.32%, and this is for all health centers, not only those located in or immediately accessible to public housing. So there are still many things that we can do. I truly believe that we can improve the 61.3% number, and I know that there are several promising practices and several things that health centers are doing to address this public health crisis affecting not only the U.S. population in general, but is more prevalent in the vulnerable populations that we see every day. Next slide. Again, numbers taken from HRSA, and these are the latest numbers. In public housing, when you compare public housing with all health centers, we're talking about 107 health centers who are close to or immediately to public housing developments, and the 13 plus, almost 1,400 FQHCs. The percentage of overweight patients are about the same, 25%. Next slide, please. Obesity category, we have if the BMI is between 30 and less than 35, is class 1. Class 2 is between 35 to less than 40, and everyone with a BMI of 40 or higher is considered as that it has severe obesity. Next slide. This is an example of a person who is 5'9", and the different BMIs and how we can categorize this person based on the BMI that we find and based on the height of this person. So I'm not trying to go over the details, but this is a good way to see and analyze the numbers when we have a patient who is overweight or obese. One of the things that I would like to mention as well is that even though we are talking about diabetes prevention and prediabetes, is we are just a step away from diabetes. We don't have numbers, or at least at the health center level, health centers are not reporting A1Cs. So it's a bit difficult for us to say who has prediabetes, but we use this indicator, the risk factor, and the obesity indicator. So we have at least an idea that person who are obese are more likely to develop diabetes. So this is something that we also need to take into consideration when we analyze these numbers. Next slide, please. We've been talking to many health centers, those located in or immediately accessible to public housing. We know that most, if not all, health centers and populations experience almost the same challenges. One of the challenges is the access to healthy food. In general, we have a very the society that consumes a lot of carbohydrates, and because of different issues, because as Fide mentioned in the very beginning, 93% of those living in public housing are low income. To access healthy food is expensive, and sometimes is one of the challenges for them. We can offer all kind of education and all types of education, but the main concern is that regardless of the education, is how accessible the healthy food for our populations. Next slide, please. The other big issue, and not only in low-income population, but the U.S. population in general, is that we are not exercising enough. Now we have our children with video games, and they stay more inside, and they don't go out, they don't play as we used to, and that's going to be a big challenge and a big factor in the now that we have all these video games and computers that are very easy to access, and in reality, the kids are not exercising enough. Next slide. It's the same in the adult population, and I really do like this slide. We have, all these new gadgets We are not walking enough. We are not exercising enough. Now we have these electric uh, skateboards and bicycles, and we are not exercising. So that is going to affect in the future, regardless of whether or not you have access to healthy food, regardless of no, regardless whether you have the income that you need to access healthy food. The thing is that there has to be a balance between exercise and the type of food that we consume every day. And at this moment, the reality is that we are not exercising enough, and technology is not helping sometimes. Next slide. There are some challenges that are specific to the public housing population. As I mentioned, 93% of those living in public housing are low income, and there is a large percentage of those living in public housing who are also uninsured. The public housing developments are located in culturally diverse communities. Sometimes it's difficult for them to understand, especially if you are around newcomers and immigrants who are not integrated, in the culture, and they have issues, language barriers. The other big issue is food adherence to self-management. We have a lot of recommendations. Diabetes and prediabetes and obesity are very complex conditions that we need to make sure that people understand. The other main issue in public housing is the lack of transportation and travel distance. One of the slides that FIDE went over showed the percentage of households with at least one person with disability in public housing, which is about 38%. And we need to make sure that we also address the lack of transportation of the distance, and offer services to our populations based on these barriers. The other one in public housing is the technology, the access to technology. Even though HUD has been working, providing internet services to the public housing developments, it's still a challenge, specifically after the 3 years that we've been suffering, COVID. And since COVID has started, the telemedicine and televisit services have increased. And one of the main concerns for those living in public housing is that when we discuss with them the internet services, either they don't have access to internet services or they cannot use computers. So out of the 107 public housing primary care grantees and the 385 health centers located in or immediately accessible to public housing, these are the main challenges that we've been discussing with them for the last few years. Next slide. In addition, reimbursement is also a big issue. Just before this beginning of this webinar, Francis and I were discussing about reimbursement, and Francis will go over, a couple of challenges and things that they do in Florida to address the reimbursement issue. The provider's perception is a big concern as well. Sometimes we feel that despite the efforts that we do and everything that we try to do to help our patients, patients are either not interested or are not understanding our instructions. So we need to make sure that we also change that perception, that we make sure that we have the health educators, the CHWs who are going to help our patients, because they are very familiar with these communities, and will help to reinforce all the information that they receive from the providers. Knowledge gaps is another big concern. Diabetes, as I mentioned, is very complex. And this is always changing. There are new medications, there are new gadgets, there are new technology that we need to make sure that we address. So we have to make sure that our providers and all those involved in diabetes prevention are receiving current information about diabetes prevention and diabetes management in general. Insurance coverage is another big concern, specifically now that we are offering the telemedicine. It's been challenging, to understand what is covered and what is not covered for this type of services. Time is a huge concern for the PHPC settings, specifically when you have many patients coming to the clinic and you don't have sometimes the time to address each of the concerns that our patients have. So time has also been a big concern in PHPC settings. Due to COVID, the workforce shortage has been another issue to offer diabetes prevention, and the resources for diabetes educators are limited. We have resources, and even though we have organizations like NIDDK, the National Institute of Diabetes, Digestive and Kidney Disorders, offering resources, and CDC and the State Health Department. Sometimes these resources are not tailored to the populations that we serve. So we need to make sure that we offer the right resources for the right populations. Next slide. So talking with health centers about some promising practices of what they are doing. One of the most important ones is the pre-visit planning, making sure that when we have a patient who is a patient who can develop diabetes, or is a patient with diabetes, we get ready, we obtain all the information that we need from them, blood work results, that we get all the information about any chronic medical conditions. So we are so we get some type of familiarity when we, just before we have an encounter with a patient with either pre-diabetes or diabetes. Next slide. Again, the pre-visit planning is extremely important. This is the information that we can obtain from our EHRs, and making sure on the charts of our patients, making sure that we know exactly what our patients are on, what the conditions are, making sure that they are taking their medications. And there are some good indicators. If you provide a prescription for a patient for 90 days, and the patient is seen again, and the patient hasn't had a refill of any of the medications that he's on, that's a flag for us, and this is the pre-visit planning offers an opportunity, to re-educate our patients, and at the same time to make sure that they are receiving the right care at the right time. Next slide, please. The family-centered approach is extremely important in public housing. As I mentioned, public housing developments are located in urban areas, due to the influx of many immigrants. Sometimes it's difficult for them to understand the instructions that we're giving. So if you have, if a patient has an issue, we need to make sure that we involve relatives, those who are more knowledgeable or more familiar, either with language, with English, or if they can better understand what the condition is about, and they can help our patients to develop the meals and the exercise routines and everything that they need. So diabetes requires in general that we sometimes offer or involve a family member so we can better serve our populations. Next slide, please. The other concern in public housing is the health literacy issues and numeracy issue. Diabetes, as I've been discussing with you and with all of you, is a condition that requires a lot of knowledge, that the patient understands specifically what is happening inside their body, that they know what the glucose level are, that they understand some of the terminology. We are going to talk about some organs like the pancreas, or we are going to talk about insulin. We are going to talk about fasting. So we need to make sure that we offer this, in a manner that patient understand what we're saying. Next slide, please. The glucose testing, again, we need to make sure that they understand how to do it, when they have to do it, depending on the severity of the condition, on whether or not the patient has diabetes or is pre-diabetic, making sure that they understand. Glucose testing can be challenging for some patients. We need to keep in mind that sometimes we only think about those with patient with any disability, but we in public housing, as I mentioned, we have people with disabilities, people who are either blind or people who have some physical disabilities. So we need to make sure that they can measure their glucose, either daily or every after, or in the morning or in the afternoon, in the evening, depending on what the instructions are. Next slide. Again, health literacy, making sure that we provide the resources. As well, I mentioned in public housing, primary care, some of the issues that we've been discussing is the lack of resources that are for this particular population. And let's make sure that we have the resources that we need so people truly understand what is happening and what they need to do, how they can address diabetes. Next slide, please. I also mentioned the language barriers. Hispanic in particular like everything that is graphic. So NIH, for instance, has some materials called fotonovelas, or so there are less like small little stories about all these issues. So let's try to find wherever we can, or find the health educator who can provide this type of services as well. Next slide. The food insecurity, as I mentioned, has been one of the main concerns in public housing. We have some interventions based on the different challenges that some of the PHPCs have experienced, but we know that they are working with community organizations and starting community garden programs, or partnership, or having partnership for food donations. So this is extremely important. It's going to be different for each health center. It's going to be depending on where they are located. But these are really good practices that they have in place, and what they are doing to address this huge concern in public housing. Next slide, please. As I mentioned, numeracy is the other issue that is extremely important to address in the Hispanic population. And so we need to make sure that people understand the right the results and what it means when the results are either too low or too high, and develop the materials that they need. There are several places where we can find these resources. Again, NIH and CDC are really good places to go, but State Health Department, or even just to look for any resource and try to tailor the resource to your community. That's extremely important, and that is also allowable. CDC has a disclaimer that you can use these materials, and the only what you have to do is just to refer that this is CDC material, but otherwise you can use them, and these are free. So these resources are being used by health centers located in or immediately accessible to public housing. Next slide, please. So I'm gonna stop here for a moment, and we are going to hear from Francis Ephraim Jennings. He is the Chief Executive Officer at Canada's Health Concern, and person who has been involved in public housing primary care for many, many years. Good afternoon, Francis.
Good afternoon, Dr. Leon, and good afternoon, Fida. Next slide, please. Great. So before I move through my slides, I just want to give you a little bit. Camillus Health Concern is located in Miami, downtown Miami, and which is in South Florida. And we get funds from HESA to provide healthcare services to those experiencing homelessness. We also provide service to newly arrived. Because we are in Miami, we're very close to the Caribbean. So people who are coming from South America, the Caribbean, Miami is really the first stop. It's just a stone throw. It will take you less than an hour to go from Miami to Cuba, and from Miami to some of the Caribbean places. So we're very close. So whenever there is an influx of people coming to America, as we're experiencing right now, 9 out of 10, they usually, not 9 out of 10, most of them will end up in Miami, because Texas also experiencing some stuff with newly arrived people. So we have all kinds of people coming to seek our services, but our sole goal, why HESA gives us the money, is to provide services to those experiencing homelessness, newly arrived. This is our building, one of our buildings. So our main center is located at 336 Northwest 5th Street, which is really near downtown Miami. Next slide, please. Okay, a little bit of history about the organization. This organization was founded in 1985 by the Brothers of Good Shepherd, and now they fuse with what we call Hospitaller Brothers of St. John of God. A little bit of history, and that will help you understand why we do what we do for the population that we serve. In 65, when Fidel Castro was in Cuba, and the Cubans were fleeing from Fidel Castro's administration or regime, the Brothers of Good Shepherd from Hamilton, Canada, and then also Toronto, they came to Miami to welcome them, to welcome these refugees. So they provided them shelters, clothes, food, and everything that they need in a new city, in a new country. So that is the mission of Camillus Health Concern. Welcoming people, welcoming the poor, the weak, the frail, to make sure that at least at some point they become productive citizens. So that is a little bit of history about that. So when they came, it was a really dilapidated shelter. That's where they were operating. No significant funding to build a place that is dignified enough for them. So over time, they sought funding, and then they built a flagship, which is about 10 minutes from us, where people stay there. It's called Camillus House, which is our sister organization. We are called Camillus Health Concern. So we're one of the, as Dr. Leon said, we're one of the almost 1,400 FQACs nationally. And in Florida, we're one of the 50. Next slide, please. Every year we serve about 6,000 unique patients. That gives us almost about 35,000 visits. We have 3 sites, and then we have 3 outreach teams that take healthcare to where the people are. Because most of the patients that we serve beside shelter, beside public housing, there are those that sleep on the street, abandoned homes, under the bridges. So our outreach teams are able to take healthcare to them, to meet them where they are. Next slide, please. These are the services that we provide to the population that we serve: adult primary care, pediatric primary care, women's health, outreach, podiatry, dental, behavioral health, and then case management. We try to be a one-stop shop for the population that we serve. So once they come to us, they get everything. They get primary here, they get dental here, they get behavioral health, i.e. mental health and substance use disorders, all in the same place. And then they walk away with their medication. Next slide. The prevalence of prediabetes and obesity in public housing, Dr. Leon went through this slide, so I am not going to go over it again because it gave us a very thorough explanation of prediabetes, and so that's what this slide is about. Next slide, please. Okay, this is one of the tests for diabetes and then also prediabetes. We call it, because we have various tests, about 3 types of tests that you could do, but this one is among the 3. One of the tests is called glycated A1C test, which is very popular. The A1C test measures your average blood glucose for the past 2 to 3 months in general. And Dr. Leon was showing a picture of how to train patients to check their glucose testing. So if your A1C test that is done 2 to 3 months, usually on 3 months level basis, below 5.7%, then it's normal. And the managed care entities also use this type of ranges. But between 5.7 and 6.4 is diagnosed as prediabetes. 5.7 to 6.4 is prediabetes, and anything 6.5 or higher on 2 separate tests indicates you have diabetes. And the doctor was explaining how hard it is to test for the prediabetes, because diabetes always, when I was growing up, it's like the silent killer. You could have diabetes, you do a lot of stuff, except some symptoms that will really prompt you, that frequent urination, thirst, and others will force, let me go check, see my doctor. And that's when they will do the A1C to make sure that your percentage of blood glucose within these ranges. Next slide, please. My organization, and now I'm going to talk specific about my organization and what are we doing about prediabetes and also doing about diabetic patients. This is something that we do, we prepare every month, and we share it with our quality forum, our QI team, which is comprised of board members, our medical director, our chief nursing officer, our clinical outcomes person. And then once they're done, they share with the board. We compare, we trend it. We've been doing this for the past 5 years. So this one is a slide that I included in here. Calendar year 2021, diabetes for control was 33%. Year to date, we are 32%. And we compare that to our internal goal. So CAC, which is Camillus Health Concern internal goals for 2022, is 30%. So right now, we are shy. Our year to date is slightly shy of our internal goals. Healthy People 2030 goal is 11.6. This is extremely hard to attain, particularly if you look at the population that we serve, living in public housing, experiencing homelessness, and newly arrived. They cross different countries in South America to get here. So we're talking about food insecurity that the doctor mentioned before is so prevalent with what we do. and we defined it. So our board members get a chance to see what are we talking about. The trend help them to understand if we are performing well, we are meeting our goals, and if not, what do we do about it? I just stop here for a quick sec because I've been with this organization 5+ years now. And I remember 5 years ago, HESA was very strong, like it still is, about diabetes and hypertension. And our diabetes numbers were not impressive at all. So they put us on a technical assistance path. We got consultants that help us come up with factors that were impeding our progress and what we could do better. So we learned from that technical assistance, and ever since we make sure that we are doing what we said we're going to be doing, calling clients back, diabetes patients back, giving them the resources that they need. There's some things, some challenges that the doctor mentioned in public housing specific about medication, about transportation, and about time. This is what we do to mitigate some of the factors about the patients having these chronic illnesses. It's not just diabetes, it's not hypertension. We also have asthma, asthmatic patients, COPD, and others, which will show you a slide. So what we do to help our clients do not pay for their medication. We will put you on a sliding fee scale because it's required as a community health center. We have to put patients on a sliding fee scale. The money HESA gives to us is structured in such a way that you use it towards the population. Yes, we cannot turn anybody away. However, some institutions, that's why they survive. That's why they sustain the operations. But we made a conscious decision that if somebody's experiencing homelessness, sleeping under the bridges, abandoning homes, and come to you, you know that person really need medical attention, need clinical health services, i.e. dental, behavioral health, all of that. So once we finish that, what use is providing healthcare services to a patient, that the patient, you know the patient needs Symbicort. If the patient have some upper respiratory or need insulin for the diabetes patient, but yet they cannot afford it. Yes, some of the Walgreens, Rite Aid, CVS, and others, they provide medication at a reasonable piece. What is reasonable to me might not be reasonable to somebody sleeping under the bridges. The $4 might seem reasonable for medication, personal accountability, but $4 might be hard for someone who is not gainfully employed, someone who, because of psychosocial issues, cannot even work. So we made a conscious decision per our board and per our mission to provide medication to the patients that we serve. So they do not. We slide them, they don't pay a penny. And even if those who have a lower income, that's those above the 101 to 150 range, federal poverty level. Even those that have a lower income, if they need medication and they cannot afford, after we have slide them, we help them with the medication and we write it off. So medication, our patients who need insulin, metformin, and the rest of them, whether it be diabetic patient, working patient, you will get your medication from us for basically nothing. And in terms of, he had mentioned also transportation, we provide residents in public housing because we are not located inside public housing. We are located around public housing. There's several public housing around us. So if they're coming to us and they're having some challenges, just like those experiencing homelessness, we give them transportation vouchers. We work with the city and then we look for grants to help them so that we are able to give them transportation vouchers to come for services. Or if they come here and they're going back home, then we give them bus passes to take them to where they are. So we try to eliminate some of the things that are within our reach to do that. People at public housing, sometimes it's a little bit difficult because they're working. So if they are working, it's hard to take some time off to come and take care of their health. So we make some flexible hours, or we use our outreach team to make sure that they go to these places where these residents live that really don't have the time to come to us, whether it be early evening hours, because we are located in downtown. It gets a little bit rough with people downtown. So we go to a decent hour when they're home and then give them their medication, provide the services that they need. Next slide, please. Okay, I wanted to share, because we're talking about obesity and prediabetes and stuff like that. Similarly, as I share with you with the diabetes, this is a hypertension control blood level. You see the calendar year, what we did year to date, where we are. And then you see our internal goals, and then healthy people 2030 goal. So this is something that we are very proud of, because we do not accept the fact that we are providing services to those experiencing homelessness, to public housing residents. We like to compete with any best practices that other organizations are using to provide services. We learn from them and then believe that if we could learn and then apply those best practices, our patients are going to benefit more than just residing within ourselves, that our population don't have the money, so you're not striving to help them get better so they could become a productive citizens. So you could see our scores, the calendar year, the year to date, the internal goals, and healthy people. Next slide will show other indicators that we measure. And this is reported to the board every single month through our QI committee and then to the full board. Next slide, please. Yeah, this we report them quarterly, because we do cervical cancer screening, breast cancer screening, and others. We don't do this monthly, we do them quarterly, because we've been able to sustain high levels of these other indicators. Next slide, please. This was spoken about with Dr. Leon's presentation. It's not worth wasting your time to repeat that, but definitely there are some of the factors that really affect prediabetes and then diabetic patients, the challenges that they face, food insecurity, and then lack of access to healthcare services. Next slide, please. So what are some of the barriers to treatment? So the barriers to treatment, we broke it down for you, or the readiness or the change to treat. Has the person even accepted their diagnosis that they diabetic or they pre-diabetic? That's a starting point, because if they haven't accepted, or they don't understand the language, the literacy level of the nurses communicating to the patients, or the doctors or the clinicians do that, it makes it very challenging. Follow-up visit, can they follow up as scheduled, recommended every 3 months? Our population is even challenging, because not only we serve public housing residents, we also serve those experiencing homelessness. And those experiencing homelessness, they're very transient. I mean, they could come to us one day, you will never hear from them all year. So if the outreach team do not locate them, you'll be missing the opportunity for their 3 months to measure their A1C and then make the appropriate intervention to them. Access to medications, insurance is challenging for them to have. So that's why we give them, make sure that they get the medication that they need. Because if they have to pay for it, regardless that they're working or they're not working, it's still pretty expensive. I always give an example that I have some upper respiratory challenge. And then when I go to Walgreens to pick up my medication for Symbicort, before, even with my insurance and everything, I have to get out of pocket for $60. But we switch insurance, so it's now about $26. But think about it. I'm working, I'm making decent money and paying $26 for Symbicate. If somebody, the children and parents are on it, how would they afford? But they come to us because we also have a government program called 340B, where the government negotiate with big pharmaceuticals, AmerisourceBergen, Pfizer, and then so we are able to buy medication on 340B. And so once they need those medication, it's a fraction of what they would have paid for when they go to the other pharmacies. Additionally, in terms of medication, we work with what we call direct relief and then also Americares, that they're able to give us donated medications. They're good medications, but they want to help community health centers and others that need a medication. So we tap into that, and that supplements also what we do so that these patients will get their medications for free. And the challenge about medication management is one thing giving the medication, but are they taking it? Are they taking it the appropriate time they're supposed to take it? So those are the barriers to treatment of diabetes and then also prediabetes. Next slide. There are some environmental factors too that we have to consider as part of this challenge bucket. Social environment, when we're talking about interpersonal support, we need family support because family members, people with diabetes or prediabetes, most times might have a family member with a history of diabetes. So the support from the family is so critical for anyone who has a diabetes or prediabetes to be supported, encouraged, and then eat healthy, exercise, as the doctor said, if they could. I know there's challenges to that, but if a family member is going through it, have been able to bring his or her A1C down significantly, that person serves as a guide for newly diagnosed diabetic patients or pre-diabetic patients. Literacy, doctor spoke about that. Access to resources, we make sure that if they cannot come here, give them the vouchers, ask the street medicine or outreach team to deliver their medications for them. And then sometimes there's a conflict and stress, priority of need. Of course, the challenge being that the trade-off with housing, with food, with utilities, with safety, with all these things add up to make it very challenging for people experiencing, not just experiencing homelessness, for not only residents, but anyone that have to be treated for prediabetes and diabetes as well. So these are some of the challenges, not all of those. Next slide, please. What are some of the lessons learned from my organization when we've been there? Beside that, we got a technical assistance and put us on the right direction. Even the quality, because diabetes, the lower the number, the better. Because that's the only thing that is reversed. Hypertension and others, you could do it, but diabetes, you need to bring it as slow, the uncontrolled part of it, you have to bring it so low, poorly controlled. That's the term that we use. So individual needs assessment, lessons learned was about housing. And then the shelters, where would they even store their insulin? So we ask them to come to the clinic, or we work with our partners, the housing entities, if there's a way that the clinic will store this type of stuff so that the patients get, so the medications they get is very effective. Work conflict, people have to work, living in public housing, at the very least, there's a portion that you have to pay towards the housing authority. So they need to go to work. So how do you flex your hours so they could get a care they deserve? We use telehealth as much, but telehealth has helped, particularly during the pandemic. But it's not the same traditionally where particularly people experiencing behavioral health, mental health, and substance use disorders want to come and see their clinicians, speak with them, do group counseling, group therapies, they're sharing stories among themselves to encourage each and every one. So that's what. And with telehealth, for example, was so interesting. We did a pilot. We had some money, and then we bought 100 phones, regular phones, Apple phones, Droid phones, Android phones, and we gave to 100 patients based upon certain criteria. Some of them were the chronic illnesses, and then housing, food insecurity. So we had a set criteria, and we work with our doctors. I'm running out of time. Am I okay
Yeah.
with time?
Yeah, a little bit, but I think we can keep going for like.
Okay, good. Let me rush through. So we did this pilot, and we gave the phones, 100 phones to people. So we learned. I mean, they have to call their clinicians about twice a month, the behavioral health, dental, or whatever, and it worked. So we learned from that. As a result of that, NAC and Centene gave us 25,000 to continue, and we built upon that, and we received $1 million from FCC, Federal Communications Commission. So right now, not only are we giving them even the phones, we're giving them tablet that is equipped with blood pressure and all these ancillaries. They could be in their house, and then the data is right here with us, and we're coaching them through, and the data could be imputed right there. So that's the genesis of where we started with the pilot and where we are right now as we're doing. Next slide, please. At this point, thank you, Fida. I am at the end of my presentation.
Thank you. Thank you so much.
Thank you.
Okay.
Back to you, Dr. Leon.
Thank you, Francis, and thank you, everyone. If you have any questions, please, you can submit your question either by using the chat or the Q&A boxes, or you can raise your hand and your line will be unmuted. Also, a quick reminder, please complete the survey after this webinar. Your information is always valuable, and it helps NCHPH to improve our webinars. Also, visit our website. You can find additional information on the resources that we have, the webinars, upcoming webinars, past webinars, publications, any emerging issues. So you can come to our website, nchph.org, and you can also find a form, contact us. Feel free to submit any questions or any need that you have, and we are going to get back to you as soon as possible. Next slide, please. Please, again, complete the evaluation survey. Do we have any questions, Fide?
No, not at the moment.
Can you please advance to the next slide? And these are our contact information. Please feel free to contact any of our members in case you have any questions. And on behalf of the National Center for Health and Public Housing, I would like to say happy holidays to everyone, and thank Francis one more time. Francis, it's always a pleasure to co-present with you, and thank you so much for sharing your experience.
Thank you.
Thank you, Francis.
Thank you so much.
Fide, I see one question. I'm sorry, in the chat.
Oh, yes. So I believe it's maybe a question regarding exercise options for residents living in a densely populated high crime area with limited green space or walkable area.
Sure, and that is a good question. Based on conversations that we have had with the health centers located in or immediately accessible to public housing, based on the advisory group that we have and the clinical quality working group that we have in place, and we have the opportunity to discuss all these issues. There are some options. One of the options is that health centers are offering on-site exercise programs. You can go to the health center, and the health center will have the opportunity to not only talking about the exercise programs that they have in place, but they will provide you some education about healthy foods, about what you can eat and what you need to avoid if you are a patient with prediabetes or if you are obese. And so it's a very, very individualized option. The other one is some of them have been in contact with the park police, for instance, and they offer training and they go to parks. They offer transportation the same way that Francis was mentioning, to offer transportation to these places. And since these are places that are sometimes difficult to walk because of crime or violence, they make sure that they are in a place where park police is present, and so people can have the opportunity to walk and exercise, and at the same time to chat, and talk about the challenges, talk about other issues, talk about the some behavioral interventions that they have. So those are some of the programs that public housing primary care grantees have in place.
Mhm. Well, thank you so much, Dr. Leon.
Sorry, Peter, I think that there is another question.
Yeah,
What options could people who have mobility problems, such as people in wheelchairs? That is a great questions. A great question. Again, each program needs to be individualized, and I was doing some research specifically on this particular issue. There are some programs developed by some of the organizations working with people with disabilities, specifically the National Council on Aging, and they have a section on programs for people with disability. I encourage Maria to go to this website and find the resources that they have in place for people with physical disabilities, and at the same time, the recommendation, even from this federal organization, is that since we are talking about someone with a disability, the person who is providing the training needs to have a really good understanding about how to help with any exercise program if you have people with disabilities. So in this case, again, the recommendation, I guess, is to go to the National Council on Aging, and specifically to the section on people with disabilities, and they have excellent resources and excellent exercise programs for those with disabilities.
Okay, so thank you so much, Dr. Leon. We don't have any questions right now. Any additional questions? You're very welcome, Maria. Okay. All right.
And Maria, just to update you with the information, the National Council on Aging now is the Administration for Community Living. So the ACL, or the Administration for Community Living, has different recommendations for those people with disabilities and those over the age of 65. Well, once again, thank you so much, everyone, for the opportunity, and happy holidays. Have a great afternoon.
Thank you. Thank you all. Goodbye.
Bye, Dr. Leon.
Hi, Francis.
Mm.